Welcome or welcome back. For those of you that haven't seen any of my videos, I'm Jennifer Lyons and I'm a VTS in emergency and critical care. This week's video is going to be about pulse oximetry, hypoxemia, and mechanisms of hypoxemia. I'm posting this week's video a little bit late, so sorry about that. I had kind of a long work stretch and just now I'm getting time to getting around to filming this. So because all of the cells in our body require oxygen to live, understanding oxygenation and hypoxemia is vital to restoring good oxygenation for our patients. Just like last week's video on blood pressures, which if you didn't see that, go ahead and check it out above. We'll be going over some basic anatomy before we dive into hypoxemia. So first, air is brought into our lungs via the process of breathing, also known as ventilation. Air passes through our oropharynx, into our trachea, down our two main stem bronchi, through 5 to 6 generations of smaller bronchi, into 20 or so generations of bronchioles, which end in terminal bronchi that contain the alveoli, which is where gas exchange called respiration occurs. There in the alveoli, gases contact the blood-gas barrier, which is the thin membrane that allows, via the process of diffusion, gases to exchange from the air in our lungs into our pulmonary capillaries. The amount of oxygen that binds to the hemoglobin of red blood cells is called the oxygen saturation and is represented as a percentage, which we can measure via a pulse oximeter. Now, to fully understand all the mechanisms of hypoxemia, we need to also be familiar with the cellular physiology of our lungs. Our lungs have several different types of cells, but the two I really want you to be familiar with are type 1 and type 2 pneumocytes. Type 1 pneumocytes are large, thin cells that participate in gas exchange. They line our alveoli and take up 95% of the alveolar surface in our lungs. Type 2 pneumocytes do not participate in gas exchange, but are responsible for producing surfactant, which is the fluid material that is in our lungs that helps keep our lungs expanded and allows for gas exchange in our alveoli. In contrast to our type 1 pneumocytes, our type 2 pneumocytes only cover about 5% of the surface of our lungs. The important thing to remember is that type 1 pneumocytes cannot proliferate. So once they are mature and then they die, that is it. Whereas type 2 pneumocytes not only can proliferate, but differentiate into type 1 pneumocytes. The next concept I want to introduce you to is kind of a tough one, but it is the concept of partial pressure, which is the driving mechanism for tissue oxygenation. A partial pressure is the pressure that a gas would exert if it were contained in a space by itself. So even though there are multiple types of gases in our blood, we talk about the partial pressure of each individual gas. We care about partial pressures because for oxygen, the partial pressure is the driving force for tissue oxygenation. At a high partial pressure, oxygen readily associates with hemoglobin. Whereas at a low partial pressure, oxygen does not like to associate with hemoglobin. So because we want oxygen to associate with the hemoglobin of our red blood cells in our lungs so that our blood can become oxygenated, we want the partial pressure in the lungs to be high, and consequently the partial pressure of oxygen in our arterial blood to be high. Partial pressure of oxygen is lower in tissues where oxygen is dissociating with hemoglobin. If the partial pressure of oxygen in our blood is low, that means that the amount of oxygen or the content of oxygen in our blood is also low, which means that our blood is becoming hypoxemic. This is graphed by the oxyhemoglobin dissociation curve, which, if you've heard of it before, is a difficult concept and it's a scary sounding concept, but really what we care about the oxyhemoglobin dissociation curve is that it correlates a partial pressure of arterial oxygen to a saturation of oxygen, which we can measure cage side. The oxyhemoglobin dissociation curve plots the partial pressure of arterial oxygen on the x-axis against oxygen saturation on the y-axis. It has a sigmoid shape, which is important to remember because at high oxygen saturation, our partial pressure of arterial oxygen is also going to be high. However, once our oxygen saturation gets between 90 to 93%, we start to see a precipitous drop in the partial pressure of arterial oxygen. So you can see when looking at the curve that as our oxygen saturation starts to drop, our partial pressure of arterial oxygen precipitously goes down. And that's important to remember because once your pulse ox starts to go down, you need to be aware that your patient is acutely becoming severely hypoxemic. Partial pressure of arterial oxygen is abbreviated to PaO2, so you'll hear me refer to it as that throughout the rest of the video. And oxygen saturation can be measured by pulse oximetry, which is abbreviated to SpO2, so you'll hear me use those two phrases throughout this video. A normal PaO2 at sea level is 80 to 100 millimeters of mercury, which correlates roughly to a pulse ox of 95 to 100%. As you go up in altitude, both of those numbers start to drop, so please be aware that I am saying at sea level. Hypoxemia is generally defined as a PaO2 of less than 80 millimeters of mercury or an oxygen saturation content of less than 93 to 95%. Severe life-threatening hypoxemia is generally defined as a PaO2 of less than 60 millimeters of mercury or a pulse oximeter reading of less than 90%. It's also important to know that cyanosis does not set in until end late stage hypoxemia. For a patient that has a normal amount of hemoglobin, meaning they have a normal amount of ability to carry oxygen, cyanosis is not readily visible until a PaO2 of approximately 40 millimeters of mercury or a pulse oximeter reading of roughly 70%. That is variable based on the visual acuity of the observer and the lighting condition in the room that you're in. But in general, it's just very important to know that cyanosis is always a sign of late stage hypoxemia. However, it is important to note that if your patient is anemic and has a lower concentration of hemoglobin, they will die from hypoxemia long before you can see cyanosis. Okay, so I know that was kind of a rough concept, but I really wanted to introduce it in this video. We'll talk about the oxyhemoglobin dissociation curve in depth more later, but for now I'd like to dive into the main mechanisms of hypoxemia, which are going to be split into three categories. Category 1 is low fraction of inspired oxygen, abbreviated to FiO2. FiO2 refers to the percentage of oxygen that you or your patient is actually breathing. Because atmospheric oxygen content is always 21%, this is not a common cause of hypoxemia. However, if you have a patient that is hypoxemic in hospital on a breathing apparatus, it's very important to evaluate whatever apparatus you're using to breathe for your patient and ensure that it is delivering oxygen to them. I'd like to take a moment here to note that Atmospheric oxygen content is always 21%, not dependent upon altitude. I think a lot of us were taught in school that at higher altitude there's less oxygen, and this is not true. At higher altitude, the partial pressure of oxygen decreases because the barometric pressure decreases. So at higher altitude, oxygen does not want to associate with your hemoglobin as readily. Therefore, people and pets that live at higher altitudes typically have lower natural PaO2s. They compensate by hyperventilating to some degree. The second mechanism of hypoxemia is hypoventilation, or not breathing enough. The hallmark of hypoventilation is an elevated PaCO2, which is the partial pressure of carbon dioxide. When we're breathing normally and we're respirating normally, we are breathing off carbon dioxide. In a patient who is hypoventilating, carbon dioxide will build up in their blood. Therefore, their PaCO2 will be higher. One way we can measure this outside of using some kind of blood gas instrument is if our patient is intubated, we can quasi-measure PaCO2 by measuring our end tidal CO2, or the amount of CO2 that we are exhaling or that our patient is exhaling. This is roughly 5 millimeters of mercury less than our PaCO2, but it is a good measurement to see if your patient is hypoventilating. If our patient is hypoxemic from hypoventilation, they should respond to oxygen support. Examples of hypoventilation are patients that have been oversedated and their respiratory drive is decreased from their drugs that have been administered to them, and pleural space disease, so a pneumothorax or severe pleural effusion. The third mechanism of hypoxemia is called venous admixture, which sounds harder than it is. All venous admixture means is that somehow blood is making it from the right side of your heart to the left side of your heart without being oxygenated. So somehow blood is bypassing the lungs or bypassing your body's ability to oxygenate it and then going into peripheral circulation again. Venous admixture is further broken down into 4 different categories. The first type of venous admixture is a low ventilation to perfusion ratio, which you may see abbreviated as V/Q, which stands for ventilation perfusion. What that means is that there's a region in the lungs that is being perfused but underventilated. So there's something preventing the lungs from appropriately bringing oxygen into that portion of the lungs so that the blood can be oxygenated. Causes of a low ventilation to perfusion ratio are low ventilation or really high perfusion. Examples of that would be airway collapse or a pulmonary thromboembolism. A low ventilation perfusion ratio should respond to oxygen support. The second type of venous admixture is a more severe form of the first, so that is a region of 0 ventilation to perfusion, so 0 VQ. This means that a region of the lung is absolutely not being ventilated, therefore all of the blood going to that region of the lung is not being oxygenated to any degree. Causes of 0 ventilation perfusion are airway collapse, such as is seen in atelectasis. This type of hypoxemia is not responsive to just oxygen support, but is responsive to positive pressure ventilation and the administration of PEEP, which is positive end expiratory pressure, which we're going to go over in another video as well. The third type of venous admixture is a diffusion defect or a diffusion deficit. And this is why I wanted you to know the different types of pneumocytes. In a diffusion deficit, you have damaged type 1 pneumocytes, meaning the cells in your lungs that are responsible for gas exchange are damaged and not functioning. This causes hypoxemia because once those type 1 pneumocytes are damaged, our type 2 pneumocytes, the surfactant secreting pneumocytes, will start to proliferate and eventually will differentiate into type 1 pneumocytes. But before they differentiate, we have a severely impaired ability to exchange oxygen in our lungs. Examples of things that lead to a diffusion deficit from damaging our type 1 pneumocytes are smoke inhalation, severe systemic inflammation, and oxygen toxicity. The last type of venous admixture is a right to left shunt. A right to left shunt is caused by any congenital defect that causes blood to travel from the right side of the heart to the left side of the heart without being oxygenated, so bypassing the lungs. An example of a congenital defect that causes right to left shunting would be tetralogy of flow, which is a combination of 4 different cardiac abnormalities that lead to right to left shunting. Unfortunately, anatomic right to left shunts are not responsive to oxygen because, again, the blood is bypassing the lungs, and oftentimes are not responsive to any kind of medical therapy, but require surgical intervention in patients that have a surgically correctable disease. So now that we understand how our patient can become hypoxemic, it's time to talk about how to diagnose them as hypoxemic, which means the bedside use of a pulse oximeter, which, if you've seen any of my other videos, you know is my absolute least favorite diagnostic tool because it is time consuming and often inaccurate. But I'm setting that aside for right now, and we're talking about the instances in which our pulse oximeter gives us a reading. So first, I think it's important to know how a pulse oximeter works. A pulse oximeter measures our arterial blood's oxygen saturation by using spectrophotometry, which means essentially that there is a light emitting diode that is emitting 2 types of light: red light and infrared light. These 2 wavelengths of light are emitted into the tissue that the pulse oximeter is sitting on. Deoxygenated blood absorbs more red light and allows more infrared light to pass through the tissue, whereas oxygenated blood absorbs more infrared light and allows more red light to pass through. So then there's a sensor on the other side of the pulse oximeter that calculates the amount of light that has passed through, uses an algorithm to convert this into a percentage, and so we have our pulse ox reading. There are 2 different types of pulse ox probes. The first is the most common one, which is a transmission probe, so it passes light from one side of the probe to the other. The second is a reflectance probe, which passes the light through, which is reflected back to a sensor on the same side of the pulse ox. Transmission probes come in all different shapes and sizes to reflect the shapes and sizes of the patients that we treat. And in general, some may work better in different instances than others. The reflectance probes can be really good for patients that you're having a hard time getting a pulse ox reading with a transmission probe. These can be used by shaving an area over an artery and then applying the probe on top of that. You can also use these rectally if you have a rectal cover for them. Common areas for pulse oxes to be placed are the gums, the tongue, the ears, the base of the tail, and in between the toes. Really an area that's high in arterial capillary beds. Most pulse oximeters will have a waveform, and the waveform corresponds roughly to pulse quality. So if your wave is very small, your pulse quality may either not be good or your pulse ox is just not reading well. Whereas if the wave or the amplitude of the wave is high, that usually correlates to a better, more accurate reading or a better pulse. It's important to know that these waveforms also come with a heart rate. And it's important to look at your heart rate and see if that actually matches the heart rate of your patient, and that will help you determine if your pulse ox is reading accurately. Now, the downside of the pulse oximeter is that they are extremely prone to artifact. The things that will interfere with your pulse ox reading are patient movement, skin pigmentation, increased ambient light, poor perfusion, anemia, cold tissues. The list kind of goes on and on. In addition, if you have a pulse ox on a thin area of tissue, the pulse oximeter probe is going to apply pressure to those capillary beds, and over time you'll see your pulse ox will drop as those capillary beds have too much pressure on them and are no longer refilling as they should be. So you often need to adjust where your pulse oximeter probe is if you're monitoring a pulse oximeter for an extended period of time. Some studies have shown that if you put a wet, moist gauze in between the tissue and the pulse oximeter probe, you can increase your pulse oximeter's accuracy. It's also important to keep in mind that your pulse oximeter will not accurately reflect your PaO2 in cases where there are other types of hemoglobin present, such as carboxyhemoglobin, as in with carbon monoxide toxicity, and methemoglobin, as seen with acetaminophen toxicity. All right, well that is it for today. If you guys are still watching, please like this video, subscribe to my channel, and I will see you next time. Oh, he's so cute. Good buddy. Good boy. Who's Doggy? Who are you talking?